Warm welcome to you. I'm Dr. Vincy Antony, and today we will be discussing about the Activator, which is a myofunctional appliance. The Activator was introduced by Viggo Anderson in 1908. He initially called it the biomechanic working retainer because he had made it as a retainer for his daughter who was going on vacation for 3 months. Later on, Anderson later teamed up with Hoppel, who was a periodontist, and named his appliance the Activator because of its ability to activate the muscle forces. The other names include the Anderson's appliance, the monoblock, the Norwegian appliance, and the biomechanic working retainer. The indications of the Activator include skeletal class 2 malocclusion, class 3 malocclusion, a class 1 open bite malocclusion, a class 1 deep bite malocclusion, and children with lack of vertical development in the lower facial height. And the essential criteria for given Activator is the arches should be well aligned. Both the maxillary and the mandibular dentation should be well aligned with the mandibular incisors upright over the basal bone. Contraindications of the Activator include patients with crowded teeth caused by disharmony between the tooth size and jaw size, patients with increased lower facial height and extreme vertical mandibular growth pattern, and severe proclination of the lower incisors. The advantages of the Activator include it utilizes the existing natural growth potential of the jaws. The appliance is hygienic and easy to maintain by the patient since it is removable. The appointments are usually short due to minimal adjustments, and the intervals between appointments can be made long, and it is much more economical. The disadvantages of the Activator include the treatment requires good patient cooperation. Furthermore, precise detailing or finishing of the occlusion is not possible with any functional appliance. So later on, we need a fixed appliance treatment for correction of the dental problems. Pre-treatment fixed appliance is needed in case of lower anterior crowding. Then Activator acts as a hinge and results in a backward and downward rotation of the jaw. Thus, it is contraindicated in patients with excessive lower anterior facial height. Moreover, the appliance is very bulky since it is a single component. The mode of action of the Activator is explained in 3 concepts: the Anderson-Hoppel concept, the Harwood-Woodside-Heron concept, and the transitional concept, which is a combination of the above 2. According to Anderson and Hoppel, the Activator induces musculoskeletal adaptation by introducing a new pattern of mandibular closure. The patient has to move the mandible forward to engage the appliance. The appliance is very loose fitting. So unless the patient purposefully brings the mandible forward and holds it, it will not be able to hold it in his mouth. And this results in stretching of the elevator muscles of the mastication, which start contracting, thereby setting up a myotatic reflex. This generates kinetic energy, which causes prevention of further growth of the maxillary dentoalveolar process, a distal force for the maxillary dentoalveolar process, and a reciprocal forward force on the mandible. And in addition to this myotatic reflex, there occurs a condylar adaptation by backward and upward growth. A third factor is the force generated while swallowing and during sleeping. The other concept to explain the mode of action, as we had earlier discussed, is the Harwood-Woodside-Heron concept. According to them, a passive tension caused by stretching of the muscles, soft tissue, and tendinous tissue is responsible for this action, and they called it the viscoelastic property. Hence, the bite in the Activator is raised more than the normal freeway space so that the stretching of the tissues can occur. Bite, as we said, the bite opens the mandible beyond the postural resting vertical position, and this causes a stretching of the muscle activity, whereby a buildup of potential energy ensues. The construction of the Activator, we're coming to it. As I told you, it is a single component. It consists of a single massive acrylic that seats in both the maxillary and mandibular arches. The only wire component is an upper labial bow used for retraction of upper anterior teeth. And incisal capping or a lower labial bow is sometimes done to prevent the lower incisors from tipping labially. Coming to the fabrication of the appliance, these are the steps. We first take an impression, then we go on to the bite registration, followed by articulation of the model, preparation of the wire components, and fabrication of the acrylic portion. The fabrication of the acrylic portion is done in, first we'll be acrylizing the maxillary part, then the mandibular part, and followed by the interocclusal region. This is how the forward positioning of the mandible, the bite is taken in the forward positioning of the mandible. So you basically need a working model. Apart from the study model, we'll be taking a working model and the construction bite. You can see this is a U-shaped, horseshoe-shaped sheet of wax. Okay. The horseshoe-shaped wax is 2 to 3 millimeter thicker than the original planned vertical dimension. The patient should be relaxed, and the position of the mandible is practiced. The patient is asked to repeat the forward mandibular positioning, and the indentation of the wax trim is placed on the lower cast, and the bite is taken. After taking the bite, you'll try it on the working model, and then if it is okay, you'll chill it and articulate the models in the reverse direction. This is how the bite looks. This is the wax trim as we've shown before. The bite is taken edge to edge position. The wire components, as we said, there's only an upper labial bow. It's made of 0.8 or 0.9 millimeter wire with the crossover between canines and the first deciduous molars or the first premolars. And it can be active or passive. The acrylic portion, as we said, it comes as the maxillary component, the mandibular component, and the interocclusal component. There are 4 types of construction bite for an activator. We'll be coming to the low construction bite with markedly forward mandibular positioning, a high construction bite with slightly anterior mandibular positioning, a construction bite without forward mandibular positioning, and the 4th one, the construction bite with opening and posterior positioning of the mandible. The first one, we can see it's a low construction bite with markedly forward mandibular positioning. Basically, the mandible is placed forward to a considerable extent, that is around 7 to 8 millimeter, with a minimal vertical opening that is around 2 to 3 millimeter. So this type of activator is called a horizontal or edge activator. There is more of advancement and less of a vertical opening. And this type of bite is usually taken in a class 2 division 1 malocclusion with a horizontal growth pattern. The second one is the high construction bite with slightly anterior mandibular positioning. Here the mandible is positioned less anteriorly, so there is less of sagittal advancement and more of vertical opening, that's around 4 to 6 millimeter. Ideally, the vertical opening is around 4 millimeter beyond the postural resting position. The activator constructed in such a manner is called as a vertical or a V activator, and it's usually given in a class 2 division 2 cases with a vertical growth pattern. The third type of construction bite is the construction bite without mandibular forward positioning. In deep bite malocclusions, the actuators are designed and trimmed to permit the extrusion of molars in deep bite cases caused by infraocclusion of molars. And in open bite malocclusion, the bite is open 4 to 5 millimeter to develop sufficient depressing force on the molars that are in premature contact. The 4th type of construction bite is opening and posterior positioning of the mandible. This type of bite is usually taken in a class 3 skeletal malocclusion. The bite is opened vertically by 5 millimeter and the posterior placement is around 2 millimeter. This type of construction bite is used for the class 3 malocclusion and is called a reverse activator. This is the activator, a picture of an activator completed, and this is the trimming done with a honeycomb appearance as seen. You can see in the posterior region. Coming to the trimming of the activator, this is a very, just like the fabrication, this occupies an equally important role for the correction of the skeletal component. So we'll be dealing with the trimming of the activator in 3 dimensions: the vertical, sagittal, and transverse. For correction of the vertical discrepancy, that is for the intrusion of teeth, the incisal edges in the case of the anteriors are the only portions that are allowed to remain in contact with the acrylic. Furthermore, the label bows are used so that they are placed below the area of maximum convexity so that you get some amount of intrusion. For the extrusion of teeth, it's done in reverse. The lingual surface is loaded above the area of the maximum convexity. The acrylic portion is placed, you can see, just above the area of the maximum convexity. And also for the anterior region, when you place the label bow in the gingival 1/3 of the label surface, you get an extrusion of the anteriors. For correction of sagittal discrepancy, if you need protrusion of incisors, the lingual surface of the tooth is loaded with acrylic, and also you can see these black dots. These are the label bows. They are kept passive and kept away from the teeth so that the teeth are pushed forward. For protrusion of incisors, the acrylic is trimmed away from the lingual surface, and an active label bow is used to bring about the retrusion. You can see the label bow touching the incisors. And for movement of the posteriors, depending on the existing malocclusion, the molars are allowed to move mesially or distally by loading the distal lingual surface or the mesiolingual surface respectively. You can see the trimming is done to permit mesial or distal movement accordingly. And for correction of the transverse discrepancy, the buccal movements of the teeth can be brought about by allowing contact of the acrylic on the lingual surface of the teeth to be moved transversely. You can see by placing more acrylic and allowing it to touch the lingual surface, you get a transverse movement. The problems encountered with the activator include difficulty in tolerating the appliance. And there could be many reasons actually. One of them could be feeling of the foreign body sensation to the appliance, the bulkiness of the appliance, and excessive bite opening or forward advancement of the mandible in the construction bite. Another reason could be the discomfort and pain. So that could be due to the poor fit of the appliance, a roughened tissue surface, sharp edges and unrelieved undercuts, overextension or sharp margins or soft tissue impingement, distortion of the label bow when used as a handle to remove the appliance. As I told you, this is a very important topic. It can come as a single essay, the activator, or the short notes could be as a construction bite, the concepts related to the mode of action of the activator, and trimming of the activator. Thank you.